Thank you for your kind introduction. I'm deeply honored to make a presentation here today. Um, uh, Immune therapy on prostate cancer has gained much of the attention these days, and so is adoptive cellular therapy for prostate cancer. So I'm going to make a brief introduction on this topic today. On the website of National Cancer Institute of the United States, we can see the clear definition of adoptive cellular therapy. And it says, in this therapy, T cells are usually taken from the patient's own blood or tumor tissue, and it is grown in large numbers in the laboratory and then finally given back to the patient. There are several types of adoptive cellular therapy, as you can see here. And the first one is tumor infiltrating lymphocyte therapy. And it has several steps, as you can see in this picture. First, T cell that has already infiltrated to the tumor tissue is isolated and activated, and then expanded to a large number and given back to the patient. And the next one is engineered T cell therapy, and it has one more step before activating T cell, which is instead of using the naturally occurring T cell, the T cells are equipped with new T cell receptor, which can better personalize to individual patients and probably bring the better outcome. And then chimeric antigen receptor T cell therapy. Usually T cells can target and eliminate cancer cells which present their antigens by binding to major histocompatibility complex or MHC. But the key advantage of this CAR T cells is that its ability to target cancer cells, which even if they do not present their antigens by MHC, so it can kill the cancer cells more effectively. So among these different types of adoptive cellular therapy, the chimeric antigen receptor T therapy or CAR T cell therapy is most widely studied to treat prostate cancer. So before we discuss about the CAR T cell therapy on prostate cancer, we need to look at the structure of CAR T molecules. This CAR molecule can be divided into three components. And the extracellular domain is composed of single chain fragment, and its main function is to identify the tumor-associated antigen. And this single chain is fixed on T cell by transmembrane domain. And the intracellular zone plays the key function of CAR T cell, which is inducing the signal transduction for T cell activation. So CARs can be classified into four types based on their molecular complexity. And the first generation CAR T cell is simply composed of three components. But given the lack of co-stimulatory molecule, it has poor persistence rate of T cell activation. So these co-stimulatory molecules are inserted to the molecule of second generation CAR T cell, which can prolong the persistence of T cell. And in second and third generation, multiple co-stimulatory molecules is inserted that even further increase the extent of T cell activation. And lastly, the fourth generation has both co-stimulatory element and also a pro-inflammatory factor such as interleukin 12, which even further increase T cell efficacy. So there are several well-known prostate-associated antigen and well-known strategies for CAR T cells. So most of all, the identification of prostate antigen is the most important step to develop an effective CAR T cell therapy. And ideal antigen should be specifically expressed by cancer cells that can make CAR T cells to develop a cancer-specific response and thereby sparing healthy tissues. And they're well known, these tumor-associated antigen associated with prostate. And the representative antigens are prostate-specific membrane antigen, or PSMA, and prostate stem cell antigen, or PSCA. And I'm pretty sure all of you know pretty well about these antigens, so I will not make any further comments on this. And in this study showing the efficacy of CAR T cells targeting the human PSMA, the authors manufactured the CAR T cell by transfecting slow viral vectors, and they also used bioluminescent reporter gene to track down the T cell in vivo. And as you can see in these graphs, the decreased tumor dimension and increased overall survival was noted in those treated with anti-PSMA CAR T cell. However, in this phase 1 clinical trial studying the efficacy of first-generation anti-PSMA CAR T cells, as you can see here, only these 2 patients out of 5 enrolled patients achieved only partial response, which showed the unsatisfactory results due to weak persistence of CAR T cells. So there have been many efforts to prolong the persistence, and in this study, the authors tried to block TGF-beta to increase the anti-tumor ability of CAR T cell. And as you can see here in these pictures, increased cytokine secretion and the induction of tumor eradication was observed in aggressive prostate cancer mouse models by blocking TGF-beta. In this recent study, also investigating the efficacy of anti-PSCA CAR T cell, we also can see this time, we also can see the specific lysis of PSCA expressing cells when introduced, when the anti-PSCA CAR T cell was introduced. And this study also shows the importance of co-stimulatory signaling domain, also in anti-PSCA CAR T cell. And they used this 4-1BB intracellular co-stimulatory signaling domain to increase the T cell surface, T cell persistence, and increase the tumor killing ability of anti-PSCA CAR T cells. Although I've shown you some promising aspects of CAR T cell therapy on prostate cancer, there are still lots of limitations on this therapy. And T cell persistence, as I mentioned earlier, is the most important and always the important problem on this therapy. And so the researchers have developed next generation of CAR T cells, as I mentioned before, and they also performed RT or chemotherapy before T cell infusion or administration of oncolytic viruses. But at present day, none of them yet showed us satisfactory results. And tumor trafficking is another big problem, especially in solid tumors like prostate cancer. And harsh tumor microenvironment is another big problem. For example, like low nutrients and oxygens and many immunosuppressive cells and reactive oxygen species that together makes a very harsh environment for CAR T cells. And lastly, the immune-related adverse events is another big obstacle to develop an effective CAR T cell therapy, like cytokine release syndrome that can cause severe inflammatory reactions and sometimes can be life-threatening in some cases. And these CAR T cells can also attack normal cells that can cause autoimmune disease and damage the organs. So at present day, to clinically implement this CAR T cell therapy on the real clinical practice, many questions should be answered. And the most important and first question is, what is the best tumor-associated antigen to induce safe and effective T cell activation? And the next one should be, what is the best way to reduce reactive immune-related adverse events? And there are many other questions should be answered to solve this problem. So as a result, although CAR T-cell therapy have shown interesting results in preclinical studies on metastatic prostate cancer, their clinical use requires further in-depth investigation. Thank you for your attention.